Okay, so this is going to be a little bit of a foray into paying attention to deformity principles, but also the wariness that you may be creating deformity or making the patient's pathway towards deformity a real and accelerated event. So let's just start with this case, and here's where I want it to be a little interactive. So this is a 54-year-old gentleman with back and leg pain, neurogenic claudication, has some weakness in his EHL and looks slightly list forward on standing. He has a history of laminectomy and posterior fusion from 4 to 1. Cody, what do you see as anatomic issues and pathologic issues on this imaging?
Looks like he's got intralisthesis at 5'1" and some stenosis. Hard to tell how bad it is from this single lateral cut, but at 3'4".
And so he's at a fusion from 4 to 1. What do we call that at 3-4 generally?
Adjacent segment.
Adjacent segment disease, correct. What do you notice about the L5S1 segment and the sacrum? Does he have normal lumbosacral anatomy?
Doesn't look.
Probably not, right? He probably has a transitional type of anatomy. So just things that you can even pick up or recognize on an MRI. And that was the workup, and this is the surgery he underwent. So a lateral surgery, pretty slick, MIS, little plate, resolved his immediate symptoms. Goes on to fuse, but he continues to have moderate, persistent low back pain. And if you look at his lumbar radiographs here, you start to get a sense that maybe there's an alignment issue, although they're focused. If you pan out, you see some other issues. You see he's got a little bit more thoracic kyphosis than average, and his SVA is considerably off. It's out here, and his overall sagittal alignment from his external auditory meatus is even worse. So this is a gentleman that has had and has a significant mismatch, even accounting for the transitional anatomy, which you see down here with his pelvic incidence being drawn at the top of the motion S1 level, not the anatomic S1 level within the transitional anatomy. So these fusions initially and then subsequently were done without a real recognition that he was in a sagittally malaligned condition, and really on the heels of the L5S1 level being predominantly the foundational problem here. He had a spondy, it's flat, fused. And so now you've added 3 levels of stiffness with a flat takeoff in a setting where he really just had degenerative features initially. So this has long been one of our challenges in spine, the infamous flat back syndrome. In yesteryear, where really we predominantly did posterior lateral fusions, this was not that uncommon because there were a fair number of people that were set up for this through their anatomic condition before surgery, and then we bake in this malalignment and we make it stiff, which is a double whammy. There's no compensatory allowance at that point. And so it becomes increasingly symptomatic. So he, not only did he continue to have back pain, likely as a result of sagittal plane abnormalities, but he developed fairly rapid recurrence of leg pain and yet another adjacent segment disease, which is where we'll focus some of our energy in this talk in terms of the factors involved in that development. So why did he keep failing? Well, there are multifactorial reasons, some non-modifiable, such as age and genetics, stiffness. And then there's modifiable muscle weakness and damage, whether it's iatrogenic through our surgical assault, RFA, all those things, as well as just aging. Gender plays a role in sarcopenia. So there are things that we can change or avoid in allowing for patients to be more resistant to adjacent segment disease. And then alignment plays a role that we'll discuss a little bit more. And the alignment comes in both regional, global, and even segmental directions. Just a little bit of a primer again to ensure everybody's on the same page. The sagittal plane parameters of importance, and those really highly related to health-related quality of life outcomes, are the pelvic incidence and lumbar lordosis match, which should be within about 10 degrees. And that can vary a little bit at the extremes in terms of the relationship between those two numbers. The sagittal vertical axis, or T1 angle, and then the pelvic tilt. So these are derived very much out of the deformity literature, but nonetheless they're important to recognize, because as we start doing fusions, particularly with patients that are out of alignment in some way in these regional or global parameters, we influence these in a direction that's less ideal for the patient. So this is the most important, and really particularly so with degenerative treatment. You have to pay very close attention to this, and as well as the harmony in that lordosis, where the lordosis occurs within the lumbar spine. And the SVA and T1 SPI are second, but also very important, and we'll go over those a little bit more. So this is more of a global alignment parameter in the sagittal plane. Okay, and then the pelvic tilt, which is an important number to look at, not just as a static one, but it is compensatory. It changes in response to other malalignment abnormalities, as you see in this picture. So as a patient develops other areas of malalignment, their pelvis will roll under typically to allow the global positioning of the spine to come backwards. And so the plumb line is more normal, or closer to normal than otherwise would be the case. Occasionally you'll get the other direction, but most often you get this retroversion. So I think most degenerative spine surgeons who aren't doing deformity have said this at one point in their career. Hopefully that's less the case for our younger trainees, but why do I have to pay attention to these regional and global alignment numbers? I'm just doing a one-level fusion. That may be a reasonable consideration if you're just doing a very limited decompression, preserving the anatomy. But the minute you go into reconstruction mode and fuse the spine, you add a stiffness factor that further undermines compensatory mechanisms and leads to greater disability if you don't aim well. So what are the mechanisms of compensation? The sagittal plane allows for thoracic hypokyphosis to occur for many people. This is subject to their neuromuscular control. Patients that have poor neuromuscular control of sarcopenia may not do that, or if they have very stiff thoracic spines in kyphosis, then they may not be able to straighten their thoracic spine. But unless you do a long alignment film, you may not recognize that this is occurring. And many patients with lumbar relative kyphosis will generate a relative lordosis of their thoracic spine to compensate. You can also get cervical and occipital hyperlordosis to keep the field of view, or the chin-brow angle and vision, if you will, out to the horizon rather than looking at the floor, which would otherwise be induced if the neck was stiff and you had a sagittal plane abnormality. We already talked about pelvic retroversion and a verticalized sacrum. And then you'll get knee flexion and hip flexion in many patients to try to bring their head back over their pelvis. But there's another compensation that gets down into even the segmental realm. So you get regional, as you see with thoracic. You can get global, and you can even get segmental compensation to make up for losses on a segmental basis. This is an example here on the right of how a lumbar lordosis may be maintained relative to the pelvic incidence despite what would seemingly be a fairly substantial loss of segmental lordosis. If you look at L5S1 in this picture, you'll see there's essentially no disc. There's complete loss of any segmental lordosis, yet the pelvic incidence and lumbar lordosis are well matched. This is likely occurring as a result of compensations above, with some unclear distribution, but certainly L4-5 is very, very lordotic relative to what one would typically expect if L5S1 was in the normal condition. So the simply looking at the lumbar lordosis and pelvic incidence may not tell the whole story, particularly when you're doing degenerative spinal reconstruction. In this case, you might be lulled into thinking a posterior fusion alone and in situ fusion at L5S1 would be rational and reasonable because of the match of the PILL. In fact, I would posit that's not true. So in this case, a 58-year-old woman with this long history of back and leg pain and failure of non-operative treatment, and this reasonable match between PI and LL, if you really look closely, likely has this hyperlordosis of L4-5, demonstrating that segmental compensation potentially. You can see our 22-degree angle at the L4-5 level and only a few degrees at L5S1, where you'd expect just well, not the opposite, but you'd expect with a PI of 65, probably a 25-degree-ish L5S1 level. And so what happens when you reconstruct L5S1 with a more appropriate interbody implant? I think this was actually 15-degree implant, but you get an improvement in L5S1 and a softening to 10 degrees from 22 degrees at L4-5, and yet a maintenance of the lumbar lordosis. So you're redistributing the lordosis, and the levels above reciprocate once you restore normalcy to the level that's collapsed. So important point there. Now, if you look at this beyond this compensatory nature and then the reciprocation, the other thing to recognize in terms of adjacent segment disease is why that may occur. And if you look at finite element analysis, and Sentler here did this work with Rothenfluh, who really is one of the great minds, I think, in this realm today out of Oxford. They looked at shear forces at the L3-4 and L4-5 levels in the setting of a fusion blow. And what you see here is that you get a higher level of shear force. And this actually goes up when there's malalignment. And you can see here that the number of levels of fusion also increase the level of shear forces from 15 to 23%. It's a difficult thing to study clinically, particularly with respect to the amount of lordosis achieved. This is an abstract that was presented at one of our meetings a few years ago, and it was 118 patients, retrospective review, and they looked at posterolateral or circumferential 1 or 2 level fusions, really aiming to see if there was influence of segmental sagittal alignment on the development of adjacent segment disease. And they number one, they didn't look terribly long. This is only a minimum of 1 year, which may not be enough to really tease out adjacent segment deterioration. I would suggest you probably need to go out 4 or 5 years to really get strong power with such a small subject number. But what they found was that, interestingly, the adjacent levels, so they fused 1 or 2 levels, and only changed those surgical levels about 1 to 2 degrees. And yet in the follow-up after a year, there was an increase in overall lumbar lordosis. And you ask, how can that be? Well, most likely, and this was just an abstract, they never published it to my knowledge, they had an ongoing compensatory adjustment above. So the levels above were trying to compensate for what was really not optimized in the surgical fusion levels. If you look more regionally, not just segmentally, Rothenfluh did one of the early studies on looking at not optimizing pelvic incidence and lumbar lordosis in reconstructions, and found that those patients that had a mismatch greater than 10 degrees after a 1 or 2 level fusion had a 10-fold increased risk of adjacent segment disease. So essentially, if you're not looking at that regional alignment and optimizing it through the course of your reconstruction, if you leave them out of regional alignment, you are giving your patient essentially a 10x risk of failing above over what they would have should the exercise have been more thoughtful. Pretty compelling. This has been looked at by other groups as well. This is Matsumoto's group in Japan, and they found somewhat similar findings. They propensity matched controls and adjacent segment disease groups of patients after PLIFs at L4-5. And as you can see here, they really didn't change. In fact, they got a little kyphotic at the level of fusion, which is not unusual with PLIFs or TLIFs. And the adjacent segment disease group was found to have a higher pelvic tilt. They had an average of 27 degrees of tilt versus 22 in the group that did not develop adjacent segment disease. They had greater rates of abnormal SVA. 50% of them had more than a 5 centimeter positive SVA versus only 21% in the control group. And then the mismatch of PIL was present in 75% of patients with ASD and only 40% of those in the control group. So a preponderance of malalignment led to greater risk of ASD. This meta-analysis also looked at risk factors for adjacent segment disease after posterior lumbar fusions and found all of these factors were associated, but on an alignment basis, specifically the patients with higher pelvic incidence and sacral slopes, as well as elevated SVAs, tended to have higher rates of ASD. So you have to pay attention to alignment if you're going to do your patients right long-term, even though you may help them with their short-term needs with degenerative surgery. So here's another look, and this is along the lines of what Centelor did. This is more of an FEA, really intricate look at influences of the muscle control, fusion, shear forces, and they basically simulated in this analysis an L4-5 fusion, and found that there were up to 115% increased shear loads at L3-4 and 73% at L5-S1. So they affirmed what we've gleaned from our literature thus far, which is the level above the fusion tends to see more challenge than the level below. But they also found, interestingly, that there was an influence of the L4-5 alignment. So those patients in the condition of hyperlordosing L4-5 during reconstruction, there was a 20% reduction in compression forces and moment at L3-4. And opposite that, if they kyphosed L4-5, so there was an increase in compression load, shear force, and moment arm. So another confirmation that malaligning a reconstruction, even at a single level, leads to abnormal forces at the adjacent levels. So what are the
Bob?
Huh?
Hey, quick question on that last one.
Yeah.
That FEA analysis for the adjacent segment stress, was that an instrumented fusion for the levels above and below? Do you remember?
No, I mean it's an FEA, so they're just saying it doesn't move; it's stiff now.
Okay, got it. Okay, got it.
Yeah, I mean I don't think there's just hypothetically, my bet is there's not much difference between those, honestly, relative to the normal condition. If you're trying to tease out what difference that makes. And in fact, in their analysis, the stiffness of the alignment of L4-5 was less impactful as a factor than the muscle control and the stiffness. So stiffness mattered, muscle control mattered a lot, and then the segmental alignment mattered, but it wasn't weighted quite as much, but still important. The key to success in planning, obviously, is getting proper radiographs. At least in degenerative spine, you have to get the femoral head. You have to know what that regional alignment is from L1 to S1, what the normal is for that patient relative to their pelvic incidence, and then you'll have to do some additional calculations as to where they are missing segmental lordosis. So just as I showed you with that, one of those first examples, knowing that there's a well-matched PILL is not sufficient. You have to also be able to determine normalcy within each segment to prescribe your treatment. And then, as we know with deformity patients, really be aware, especially of those patients that are more at risk. Those patients with high pelvic incidence, as you saw, tend to have a higher rate or risk of adjacent segment disease. So you have to pay much more attention to them than those patients that have a real flat sacral slope or low PI in order to get it right. This is a bit of a moving target. There are different calculations that will be formulated over time. I think the 2/3 rule keeps it pretty simple and easy to do this on the fly and not feel like you're over engineering. That means basically that 2/3 of your lumbar lordosis should exist from L4 to S1, and 2/3 of that should be at L5 S1. If you can follow that basic rule, you'll do your patients well the vast majority of the time. As we get more and more intricate with the Rusali characterizations and distribution of lordosis, and that's going to be particularly true with the high PI and low PI patients, then you can adjust this subtly as you're reconstructing those levels. And as I said before, really pay attention to the adjacent levels and recognize what they're doing from a compensatory perspective, and acknowledge that they will likely reciprocate over time. Here's another example of a patient with a spondy at 5.1 and a fairly flattened 5.1 level. You can see this 5-degree angle at 5.1 preoperatively, 17 degrees at 4.5, sort of flip-flopped in terms of ratio, and then postoperatively with I believe a 15-degree cage at the time, and then postoperatively you can see that there's a softening of L4-5 to about 12 degrees. So a 5-degree adjustment at that level alone in reciprocation. Another L4 to S1 analysis. Here's a baseline level of about 29 degrees between 4 to 1, 14 degrees at 4.5 on the left here preoperatively, and a pretty flat 5.1 level. And then with a hyperlordotic intervertebral realignment at 5.1, you get this softening above to about 5 degrees. And then overall L4 to S1 segmental alignment from 29 to 34 degrees. So you see this adjustment, reciprocation at the level above. And this can occur above those levels too. Here's yeah, go ahead. You have a question?
Yeah, I was going to,
yeah.
Oh, who? Me?
I was
going to say the other thing that's happening is like if you look at the place in space where that disc space is, it's under a lot less shear stress on a lot of those, right? So especially there, you can start seeing how 4.5 goes from being more vertical to now being more horizontal, which is, I think, for that level, likely a protective effect too.
Right. Yeah, exactly right. Here's a level above a 4 to 1 prior fusion that was somewhat flattened, and a little bit more of a hyperlordotic correction. And even above that, you can see a change in the L2-3 reciprocation. So you can still make up for some lost lordosis below. And as the FEA that I showed you, the second FEA that I showed you, hyperlordosing can actually be helpful or effective in those cases that you may have lost something elsewhere in the lumbar spine, and protect the levels above more effectively. So there's lots of different options for reconstructing. You have to know what you can accomplish in your tool bag, what implants are available to help you. You also have to know what the limitations are. If you're contemplating a posterior fusion or posterolateral fusion with or without fixation, you're not getting anything. Nothing's going to change really. And you have to acknowledge that. That may be fine in the right context, but be knowledgeable of these kind of numbers and generally in the literature what people have achieved with specific reconstructive efforts. TLIFs and PLIFs are not real aggressive, particularly MIS, at changing alignment. Now, you could do extra work. You can take out both facets and improve the odds of some lordosis change. That adds to the complexity and the morbidity of the operation. You can go all the way to posterior column osteotomies and get even more lordosis. This can be taken into the anterior column, obviously, where you have to work a little less hard posteriorly, and laterals tend to do a pretty good job, but they're not immune from failure to achieve the amount of lordosis you think you might get. I think generally in our anecdotal and literature experience, the laterals will tend to give you about 50% of what the cage is rated for, unless you work a little bit on the backside. And that's sort of a blend. If L4-5 is being done versus L2-3, you will get more natural lordosis out of the cage at L4-5 because that level tends to allow for more lordosis. At L1-2 or L2-3, you have to work harder on the posterior side to get more lordosis out of the same cage as you'd get out of 4-5. So you might have to add PCOs, as you see here, and then you can get into the more aggressive osteotomies or anterior column releases, as you see here with ACRs, with or without posterior column releases. So this is sort of a menu for adjusting your expectations with respect to your reconstructive technique, and not undershooting and not overshooting. Choosing your cages or implants needs to tend to the happenstance posteriorly of using more lordotic cages, such as foraminal stenosis. You tend to get rotational movement of the superior articular process into the foramen when you hyperlordose. And so you can manage that in some cases with increasing the posterior height of the cage and making sure that's not too diminutive. Sometimes you actually have to do foraminotomies in favor of getting the right alignment, but not impinging on the exiting nerve root. And the degree of correction depends much on the level of being addressed, as I mentioned, between, say, upper lumbar and lower lumbar, where native or segmental lordosis varies, and with the addition of releases and osteotomies. So in summary, segmental compensation may be in effect in a patient that has what you perceive to be normal lordosis relative to their PI. Do not be dissuaded into doing a suboptimal localized reconstruction in that event. Really scrutinize each segment for normalcy. And if you don't, then you may actually be leading to a higher risk of adjacent segment disease in their longer term future because of those factors Greg chimed in on, such as the shear forces being higher compressive loads, and other factors. And when you're planning lumbar reconstruction, really look at the segmental normative values and the compensation and reciprocation that will be going on, and keep those in mind. And you'll be a wiser degenerative surgeon. That's it. Any questions? Quiet.
Do we have a few minutes?
Yes, we do. Go ahead.
Yeah, my comments were a great talk, and I think that's the talk that we never heard, a few years ago. My comment was mainly on definition, and when this treatment of spine deformity in adults started, many years ago in the 70s, and 80s with John Kosterick and others. They were all sort of a deformity, adult deformity that came from childhood. It was more idiopathic scoliosis and so on. It's really, nobody really thought about degenerative conditions as deformity. And so they were sort of always a distinction between degenerative scoliosis, for instance, and idiopathic scoliosis. I think your talk sort of points out that really any type of spine, degenerative in particular, should be treated with the rules and the mind of preventing deformity and sort of having the following the rules of deformity correction, not really all going to T4L S1,
Right.
but just mainly the thing. So I think the question or the point I was making is when we get the primary degenerative changes, like we have a 15-degree curve and so on, and where do we draw the line of just a simple degenerative treatment versus going through more complex deformity? And I think that's basically where we have to have the mind of that. But do we still have that option of doing a small curve versus the right correction of difference? So where is that definition of degeneratives versus deformity sort of is? I don't know whether I can explain that.
I know what you're saying. I think the complexity of your question also has to acknowledge the risk variance, and that differs based on surgeon and where they're operating and who they have to help. We could talk about getting alignment perfect, but that ignores the reality of morbidity of the operations. And so sometimes shooting for perfect alignment may not be the right thing to do if you escalate risk to the point where the immediate risk is worse than the future risk of adjacent segment disease. And I think that's true with these short degenerative curves, if you will. Most importantly, and you've taught us all this, is when you aim to manage these, in addition to accommodating that risk profile and making sure you first do no harm, I think the main thrust of what I want to get across is try to make what you have as ideal as you can within that risk context, and not shoot yourself in the foot or make things dramatically worse for the patient in the future. So you may not make it perfect, but you should make it better. You should create a foundation of making any next or future steps easier and not catastrophic for the patient. The segmental stuff and these degenerative spines, I think we've gotten away with less ideal solutions because they don't fail quite as catastrophically. In deformity, you mismanage it in the same way. There's much more future risk and catastrophic failure. So having said that, nobody wants to have more secondary surgeries than they have to. And so I think if we get it right a little bit more than we've done in the past, we'll do right by our patients a lot more commonly.
In other words, the art of surgery and experience still exists.
That's right.
Thank you.
You bet. All right. If there's no other questions, then thanks for joining, and we'll see you next week.